Good morning. My name is Elaine Crane, and we are here to analyze a major health information technology issue through the lens of ethics. The objectives for this presentation are: present the issue. Can the electronic health record mandate impact patient safety? Provide background information on this issue. Discuss current status of EHR legislation in Maryland. Address the significance of the EHR mandate and its impact on healthcare delivery, both at the state and national levels. To me, the biggest reimbursement issue that impacts the design and use of health information technology is the ill-considered government insistence on mandating the use of EHRs in all healthcare practices across the United States. Although this assignment is to look at reimbursement and ethical issues related to health information technology, it is important to first realize that ethical choices and dilemmas start in the day-to-day practice of healthcare. Healthcare is rapidly changing based on technology's advances. In medical technology, 3D imaging and printing are revolutionizing surgery. Treatment decisions are being linked to genetic testing. New pharmaceutical modalities are being created based on genetic manipulation. And even how the public views healthcare personnel is now more influenced by the Fourth Estate and not by those practicing in the field. As most healthcare practices stay in business or become successful, due partly to reimbursement, there are some searching questions that should be asked in the big picture of healthcare reform. One potential drawback of EHRs is the risk of patient privacy violations, which is a growing concern for patients due to the increasing amount of health information exchanged electronically. EHRs may cause unintended consequences, such as a provider may lose his or her autonomy in making patient decisions because an EHR blocks the ordering of certain tests or medications. Organizations must ensure that basic medical care can still be provided in the absence of technology, especially in times when the downtime of the system may be critical. Small practices are closing due to decreasing revenue, based partly on the expense of adopting EHRs and the fines that accompany their non-implementation. A 10-minute visit encompasses the work of the phone operator, the medical records clerk, the triage nurse, the check-in person, the nurse or medical assistant, the provider, the checkout person, and the biller. It takes 8 people and at least 45 minutes of work to make one appointment happen. Plus, the visit had to help pay the expenses for the rent, the utilities, malpractice insurance, medical supplies, computers, phones, and janitorial services. While payments from Medicare, Medicaid, and private insurance companies to providers have not really increased over time, overhead has gone up dramatically. With the addition of buying and maintaining an EHR, the situation deteriorates further. And if a practice chose not to implement an EHR, the fines have the same consequences as the increased expenses. As small practices close, the pool of available providers diminishes, leaving patients without access to care. DNP 13 has looked at many issues related to reimbursement and health information technology this term. But as we enter the ethical portion of our journey, a new spotlight must be aimed on past discussions. At a Senate hearing on July 18, 2014, medical experts told lawmakers that health IT tools, such as electronic health records, are falling short in efforts to improve patient safety. Ashish Jha, professor of health policy and management at Harvard School of Public Health, said most hospitals do not track adverse events despite having the technology to do so, and, therefore, do not know how often patients are harmed. The concept behind meaningful use is to improve health and transform healthcare through the use of health information technology in a measurable way. The Department of Health and Human Services identified the following 3 stages in the process: data capture and sharing, advanced clinical processes, and improved outcomes. It also focused on 5 domains: quality, safety and efficiency, patient engagement, care coordination, public health, and privacy and safety of personal health information. According to David Blumenthal, the nation's HIT coordinator, another long-term goal of meaningful use is to have information follow a patient wherever that patient goes in the healthcare system. He sees EHR adoption as a competitive advantage for practices, both in recruiting new providers and in selling the practice. Dr. Blumenthal believes connectivity among providers, hospitals, laboratories, and pharmacies will help practices maintain their independence. Next is a video that, although making a spoof of HIT, actually has some chilling undertones.
Good morning, Mr. Smythe. You ready to go home? We could sure use this bed.
It's Smith, and no, I'm not ready to be released. Where's my nurse? Are you a doctor?
No, I'm the hospital billing director. But it definitely says Smythe on your pre-printed invoice. Let's see, it's $42,908.
Aren't there any doctors or nurses around here?
Well, of course we have doctors, but they're all busy filling out their billable hours. But we do allot our fine doctors 3 minutes and 7 seconds with each patient every day.
Well, that's dumb. Where's my nurse?
Oh, we had to let most of our registered nurses go. Have to hit those profitability numbers. But I do want you to meet your new bedside caregiver, Frank.
Is that some kind of computer?
Frank is a computer, Mr. Smythe. His name stands for Formatted Recognition Analysis Non-Human Conclusion. Frank does an all-in-one assessment, diagnosis, and care plan for you. Our consultants say this kind of nurse works great.
This thing isn't a nurse. It's not even a human. And you can tell your consultants that conclusion does not begin with a K.
Hey, we don't name them. We just buy them. Frank will be assisted by one of our highly cost-effective computer technicians, Steve.
Hey, dude, how's it hanging? Hey, tell me what's hurting, and I'll program it into Frank.
This is stupid. I want a real nurse.
As recommended by our consultants, we have spent millions of dollars on the latest non-human medical technology.
My throat is burning up. I got terrible indigestion, acid reflux, whatever you want to call it. I got a pain in both my arms.
Whoa, dude, slow down so I can get all this grossness into Frank.
My heart is beating 1,000,000 miles a minute. Feels like it's going to jump right out of my chest.
Oh, cool.
See? He's printing out your home health care instructions.
Oh, Frank's checking out your medical records, man. Sorry about that leg amputation, man. Hey.
Diagnosis.
Congratulations, dude. You're pregnant.
Frank system warning.
Uh-oh.
System error.
Frank's freaking out.
Nurse! Help! Nurse!
What is going on with Frank?
Dude, you got me, boss man.
My real nurse
Version
is here
52.1 of the manual
Nurse,
still downloading on my
help.
iTab.
Feels like there's an elephant on my chest. Can't breathe. Do something.
Didn't we have those call button thingies? We get rid of those too.
No nurses, no buttons needed. But you should probably help this dude because he's turning purple.
Nurse!
Error.
Nurse!
I'm a registered nurse. What's going on here?
We don't know.
This man may be having a myocardial infarction.
Well, can you help? Do you know how to fix a computer?
No, but I do know how to take care of patients. Don't worry, you're in the care of a registered nurse now. We need an EKG stat.
Stat. What's that?
It means that you and your computer are in over your heads. Get a doctor and get out of my way. Move, now.
Oh,
Time to
okay.
split,
I think
dude.
we need a doctor. Doctor? Hello? We need a doctor. Hello, doctor? We need a
Don't let hospitals put unproven medical technology above your care and safety. When you or your loved ones are most vulnerable, your nurse is your first line of protection and your last line of defense. Insist on a registered nurse. Registered nurses put the care in healthcare.
Oh.
The problem, says National Nurses United co-president Deborah Berger, is that EHRs are inherently billing and collection tools. Everything is about capturing the DRG and the ICD codes, she says. They never were honestly intended for improving patient care. Patient safety concerns emerge, she says, when EHR's clinical decision support functionality steers clinicians towards standardized, low-cost treatment plans without accounting for a patient's individual situation, like nurses have been trained to do. Nurses look at the patient, not just the disease, but any comorbidities, their relationship with their families. It all has an effect on treatment, and so it has to be taken into account. Despite the option to ignore the computer-generated recommendations, Ms. Berger believes the presence of the CDS can still sway clinical judgment. The people that are providing care are so frazzled and busy trying to get the care done and fill out the boxes, they're less and less likely to override a clinical best practice because it takes time, so they go with the path of least resistance. The state-regulated payer EHR Adoption Incentive Program is a result of House Bill 706, Electronic Health Records Regulation and Reimbursement, that passed during the 2009 Maryland General Assembly legislative session. The Maryland Healthcare Commission worked with the 6 largest private payers in the state to establish the incentive program, which went into effect on April 21, 2011. It was amended on October 21, 2011 to require that the incentive be paid in cash unless a provider and payer agree on an incentive of equivalent value. The incentive program was revised on June 9, 2014 in an effort to simplify some of the administrative requirements and to align with the federal EHR incentive programs. These current requirements went into effect on June 9, 2014 under COMAR 10.25.16. Incentives are available to hospital-owned and non-hospital-owned primary care practices in Maryland who adopt an EHR that is certified by the ONC. Primary care practices include family, general, geriatric, internal medicine, pediatric, or gynecological practices. Primary care practices can be led by a nurse practitioner. In order to qualify for the incentive, the primary care practice must also demonstrate that the practice has either attested to the current meaningful use requirements under the Medicare or Medicaid EHR incentive program or participates in any MHCC-approved patient-centered medical home program and has achieved recognition from the National Committee for Quality Assurance for meeting NCQA's 2011 or later standards for at least Level 2 PCMH recognition. In order to request the incentive, eligible practices submit the state-regulated EHR Adoption Incentive Payment Request Form, including required documentation to each payer with which it does business. Payers required to participate include Aetna, CareFirst Blue Cross Blue Shield, Cigna Healthcare, Mid-Atlantic, Coventry Healthcare, Kaiser Permanente, and United Healthcare, Mid-Atlantic region. The application may be submitted no earlier than October 7, 2014, and no later than December 31, 2016. A one-time incentive payment of $15,000 per payer makes adopting an EHR seem very lucrative. Governor O'Malley of Maryland held a forum on children and health IT to create strategies so that the state can continue to meet the health needs of all Marylanders. Maryland is one of the first states to embrace this technology, harnessing federal programs as well as creating state-specific